Well, good evening. My name is Ann Lorenz. I am a nurse practitioner at the Arthritis Center. I have been there for about 5.5 years, work with Dr. Churchill. And thank you for coming to our Knowledge Night event. These events are really for you, for our patients and the public, whoever wants to come and learn more about your arthritis. And really the focus tonight is on symptom management. If you have RA and a variety of other conditions, a lot of these things would apply to, but particularly if you have rheumatoid arthritis, how do you manage those symptoms on a day-to-day basis, and why do we recommend what we do? So, there we go. So arthritis, what does it mean? Arthro is the prefix for joint. Itis means inflammation. So arthritis, inflamed joints. There are over 100 types of arthritis. Not every single one actually includes inflammation, but RA does. When the joint is inflamed, it's painful and stiff, often swollen, just does not, often does not have complete range of motion. And just as a real quick review, this is a synovial joint. This is a normal joint. Around the joint is this capsule, and that is filled with normal joint fluid, and the fluid provides lubrication to the joint, nutrition to the joint. This is the cartilage, and then around the synovial lining are the other structures like the tendons and muscle attachments and things. Okay, so rheumatoid arthritis, it is a chronic inflammatory condition. So it's not that we treat it and then you're done. It is a chronic disease that needs treatment for over time. It causes the joint swelling, tenderness, and ultimately it can cause destruction in the joints. As an inflammatory disease, it's a systemic illness. So it's what we think of rheumatoid arthritis as the manifestation of swelling in the joints, but it actually involves swelling that is systemic, can cause inflammation of other systems in the body, the lungs, the heart, the skin, the eyes, and that can be a very debilitating and destructive process, and can lead to premature mortality. It is autoimmune, which means that our immune system, our natural defense against insult, becomes triggered by something, and we develop antibodies and different defense mechanisms, but they're targeted at our own bodies, and that causes lots of symptoms. So RA is typically, or 75% of RA patients are women. Often it's diagnosed in the childbearing years, age 35 to 45. Also, tobacco use is a risk factor for rheumatoid arthritis. Increases the likelihood that you will have RA, and increases the likelihood that that RA will be more severe and more difficult to treat, particularly if you continue to smoke. The reason for that is as you smoke, you inhale nicotine. Nicotine goes into the lungs and triggers this antibody response, an anti-CCP antibody, and that stimulates lots of inflammation. Also, as are many autoimmune diseases, rheumatoid arthritis has a familial or genetic predisposition. Here's some more. These are X-ray images of rheumatoid arthritis. On the top image, A is a normal joint, normal synovial joint. You can't see the capsule on the X-rays because that is soft tissue, but on the second joint, you can see that there is soft tissue swelling around there. Here it's nice and trim. On the second one, on B, there's soft tissue swelling, and there's also a beginning of an erosion right here, where the synovial lining that has become inflamed has actually started to erode into the cortex, or the outer surface of the bone. And then C is just a progression of that. There's also narrowing between these two bones. The joint space is narrowed, so the cartilage has also been damaged. So that would be an erosive change. Down the lower slide is X-rays of someone who's had RA for a long time and probably was diagnosed before we had our fancy biologic drugs. These MCP joints at the base of the knuckles have subluxed, and we see there's ulnar drift, so that the fingers kind of drift off to the side because of the damage to those bones. There's also, particularly on the right, there's evidence of damage to the wrist elements, and probably, if untreated, would progress to more changes. Here's just another normal, or another diagram contrasting normal and arthritic joints. A lot of times people confuse osteoarthritis with rheumatoid arthritis, but it's really a different process. OA, or osteoarthritis, is wear and tear, degenerative arthritis. You use your joints a lot over time, the cartilage breaks down, and you get this broadening of the bones. You get sometimes bone spurs and things. On this slide too, you can see that the synovial lining, synovial capsule, is normal. There's no inflammation there. The far right, rheumatoid arthritis, there's lots of inflammation in the synovial lining. It's distended and swollen, and we have the early bone erosion there. This is a really busy slide. This is the American College of Rheumatology's diagnostic criteria for rheumatoid arthritis. Basically, we use this when we have a patient that comes in with swollen joints for a number of weeks. And you can kind of count up their score, and if they score a certain amount, then they have RA. RA always involves swollen joints. You can't really be diagnosed with RA without having had swollen joints. We also look at the serology, which is the measurement of certain antibodies in the blood. So rheumatoid factor and that anti-CCP antibody. You can't have RA without having these in your blood. Also, we look at the acute phase reactants, which are measurements in the blood, the SED rate and the CRP. They're measurements of inflammation in the blood. And again, not everybody has elevated SED rate and CRP. We can still diagnose RA clinically without those, but often they do because there is systemic inflammation. Also, the symptoms have to last over 6 weeks. Essentially, there are other kinds of arthritis that can occur that kind of come and go. RA comes and kind of just gradually progresses. Often it'll start with just a couple of joints, just a little bit of swelling, and then it will progress to more and more joints that are more and more swollen, and you're more and more miserable. So the good news is there are really wonderful treatments for rheumatoid arthritis. They have improved outcomes, improved the standard of living for many folks with rheumatoid arthritis. The big key to diagnosis is figuring it out early, getting it diagnosed early before the inflammation really has built up steam. The sooner that we can get disease-modifying drugs started, and I'll talk about that in a minute, but the sooner that we can start treatment, the better your outcomes are likely to be. Even if you have rheumatoid arthritis like the one on the right, advanced, long-standing disease, we still can improve your quality of life, help you feel better, help prevent more deformities with appropriate treatment. Our expectations just are a little bit different in that case. So our goals, well, number one, to diagnose it early, but also to help you feel better. Obviously, minimize your joint pain, your joint stiffness and swelling. Usually with treatment also, the energy level gets better and you just feel better overall. Ultimately, we want to preserve the function of the joints, prevent the damage, keep them functioning normally, keep you functioning normally and enjoying life, doing things that you want to do. So again, ideally establish the diagnosis early on. We want to educate our patients about how to take care of yourself. What is RA? I mean, that's what we're here tonight about. What is it? Why do we order the medications that we do? What do you need to know about those, and so forth? We start anti-rheumatic drug therapy early. DMARD treatment, disease-modifying anti-rheumatic drugs. There are a variety of them. Typically, methotrexate is the first used for moderate to severe RA. That would be our standard starting treatment. If it's mild, often we'll use a medicine called Plaquenil, which is an old anti-malaria medicine that works nicely over time, but it wouldn't be enough if you have pretty moderate or severe disease. Some patients we use nonsteroidal anti-inflammatory drugs with, and this wouldn't be in isolation. This would be all added on to the disease-modifying drug. NSAIDs are medicines like ibuprofen, Aleve, diclofenac, Celebrex. There's a whole host of them. Not every patient can take them, but they have steroid-like effects, so they kind of act like prednisone in their benefits, but they don't have many of the prednisone-related side effects. So they decrease joint stiffness and pain and swelling. Sometimes we'll use systemic steroids or prednisone for a period of time. Sometimes we need to use them longer term, but our goal is always to get patients off of prednisone. Often it's used early on as a bridge therapy. So we start methotrexate and know that it's going to take a little while for it to get up to full therapeutic benefit. So we use prednisone for a while to keep you comfortable while that's getting on board. We also do a lot of injections, so local treatment with a steroid to reduce inflammation in a particular joint. Also, down the road, often physical therapy or occupational therapy is helpful. We want our patients to pace themselves, so particularly if your joints are really inflamed and you're kind of sick with your RA, we don't want you out there training for a marathon or, really pushing your body. We want you to, do what you can, but also get rest periods and treat your joints kindly particularly when they're inflamed. Part of all of this, and we'll talk about this quite a bit as we go on, is just healthy lifestyle. Taking care of your body by getting enough sleep, getting a good diet, and knowing how to take care of yourself. Surgery, fortunately we don't have to use surgery as often as they used to before the biologic DMARDs came onto the playing field, but sometimes joint replacements are necessary, sometimes correction of deformities are necessary. So sometimes surgery is an adjuvant to our medical therapy. So first order of business is to get educated about RA. There are really good websites to read about it. You're here tonight learning about RA. The nurses at the clinic, the nurse practitioners like me and Heather, your doctors, fabulous resources for learning about your rheumatoid arthritis. There's no question that's too silly or too stupid to ask. We want you to be informed, want you to know how to take care of your RA and really be equipped. And also to learn about your medications. And medications sometimes scare people as far as, getting home from the pharmacy, reading the pamphlet with all the 100 side effects that you might have. Basically, we try to educate you when we start the medication, let you know what the common side effects are, what we're watching for, and if you're not getting along with the medication, we want you to let us know. But there is a reason why we recommended it for you. We don't just capriciously give out prescriptions. We did order it for a reason. So if you have questions about it, please ask us. And then also learning about how to manage your symptoms at home. We see you for 15, 30 minutes maybe every 3 to 6 months, and all that time in between, you're left to manage your symptoms, manage your RA on your own. So knowing how to do that is important as well. So the disease-modifying anti-rheumatic drugs, they again decrease the joint pain, stiffness, swelling. but also they don't just make you feel better, they actually change the trajectory of the illness and help prevent damage. Okay, there are kind of two big classes of DMARDs. There are the non-biologic DMARDs and biologic DMARDs. Most of the non-biologic DMARDs are older agents. Some of them are borrowed, like Plaquenil is borrowed from infectious disease. It was an anti-malaria medicine that somehow along the way they figured out it decreased joint swelling. So many of these are kind of borrowed from other disciplines, but all of them have been shown to decrease joint pain, swelling, and damage. Gold we don't use very often. These kind of gold, cyclophosphamide, and cyclosporin minocycline we don't use very often, but they are options. Methotrexate, again, usually the first choice for moderate to severe. Leflunomide is a nice option for patients that don't tolerate or can't take methotrexate for some reason. It works very nicely. And sometimes DMARDs are used in combination. Even the non-biologics will use sometimes a combination of these. The newest one is Xeljanz, which patients are seeing ads for this one on TV. It is one that we did clinical studies at the Arthritis Center on. It is unique in that it works inside the cell to decrease inflammation. Doesn't just work on receptors outside of the cell like the other like biologic agents do. It goes inside the cell and inhibits JAK kinase products. And JAK kinases are stimulators of infection. So it works on kind of multiple targets, the JAK kinases, and decreases inflammation that way. It also is a pill, which is different than all of the biologic products. So the biologics, there are different, each of these have a specific target within the immune system that they basically neutralize in order to control inflammation. Usually these are used in conjunction with one or more non-biologic DMARD. There are tumor necrosis factor antagonists like Enbrel and the rest of them there on the top. Orencia is a once-a-month infusion, and now it's available as an injection. It's a nice one. It works by modifying T cell function. Rituxan is a medication that works with the B cells to limit inflammation. It's also used in lymphoma and cancer treatment. And then Actemra is an interleukin-6 antagonist. And there are lots of other ones in development. And I'll just do a quick plug for our clinical research department. There are lots of medications in development, different targets, different mechanisms of action, different modes of action. And if you have rheumatoid arthritis, probably, if it hasn't happened yet, sometime along the way you will be approached with an opportunity to participate in research. It's kind of fun, it's kind of interesting. It takes a little bit more of your time perhaps, but I think it's worth it. Patients often feel very pampered when they're on research because they get wonderful research staff to answer all their questions and kind of guide them along the way. It's really kind of an exciting thing. So if you're interested in research, let us know. So as far as self-management outside of the clinic, what do you do to manage your joint pain? Obviously, we want to minimize your joint pain with appropriate medications and things, but there are many methods of kind of dealing with pain, and many patients have really impressed me with their ability to do this. It's incredible sometimes to me. But keeping busy, keeping distracted, keep moving, learning to pace your activities, not do too much, kind of learn what you can do, what you can't do, and kind of pace yourself. Heat and cold often is helpful. Contrast or paraffin baths are techniques that we use for hand stiffness and swelling. Contrast baths are basically if you have like a double sink or two basins of water. One is hot, one is cool. You soak your hands in the hot water for a period of time, several minutes, and then you move them over to the cool water for just a minute or two, and then back to the hot. So you spend more time in the hot than the cold, but basically that alternation in temperatures does something just to loosen up the joints, get them moving. A lot of times patients will do this in the mornings to kind of get that morning stiffness out of their hands, get them moving. Paraffin baths are the wax devices where you put wax in it. The wax heats up. You submerge your hands in the wax, and they really work well to not only soften the skin, but really decrease joint stiffness. Also, again, exercise, keeping moving is so very important. We want the muscles and the tendons, all of the soft tissues around the joints to be as strong as possible to support the joints so there's not as much stress on them. We often use the expertise of physical therapists. Sometimes we have to recommend weight loss to patients. We don't feel very popular when we do this, but if you have arthritis in your weight-bearing joints, it is very helpful from a pain management perspective and a functional perspective to lose a few pounds. Also, we use occupational therapists. Often they are housed with physical therapists. Their focus is more on functional tasks. So if you have difficulty opening jars or turning the key in your car because it's too hard to grip the key and rotate the key around, they have all kinds of ideas and tools and aids to help you do that. They also work on small joint strengthening so that you can do functional activities better. Massage is helpful. Certainly, and we all, I think, have our favorite massage therapists. We can give you their name. They're often very helpful for some of the secondary muscle pains that you may have with RA. Chiropractic is kind of a gray area. Some rheumatologists, I think, are okay with that. Some are not. Generally, we don't want them doing a lot of adjustments on inflamed joints. We don't want damage to be done to the joints. But if they use physical modalities like massage and like electrical stimulation, those kind of things, it's really okay. We just don't like them popping you too much. Also, alternative therapies, acupuncture actually works. I have a number of patients that use it for various kinds of arthritis, and it really does seem to work. I don't get it, but it seems to. So for intractable pain that you can't figure out what to do with, can't seem to get under control, it is an option for you. Biofeedback, relaxation techniques, those are modalities that psychologists are trained to do, so we can certainly set you up for that if you're interested, and it is helpful. And then also cortisone injections that we can do for localized symptoms. And then pain medications. Dr. Valente makes it very clear to his patients we're not a pain clinic, and we aren't. We're an arthritis clinic, so we optimally want to treat your arthritis. But sometimes we do have to use pain medications to keep you sleeping well, functioning well, and deal with the pain that isn't quite resolved by our disease-modifying drugs and the other things that you're doing at home to manage your pain. So non-steroidals are helpful. Topical products, there are a variety of topical agents that are available over the counter or by prescription that do really help. What's nice about topicals is you can, at least the over-counter ones, you can kind of apply liberally as you need to, and they don't have systemic absorption or very much, so that's kind of a benefit, say, for people that can't take non-steroidals. We can prescribe a non-steroidal ointment and get some of the benefits from non-steroidals without hurting your kidneys or causing your blood pressure to go up or whatever. Sometimes adjuvant drugs like muscle relaxants, antidepressants, sometimes sleep medications, because if you don't sleep well, you're not going to feel so good the next morning. You're going to have more pain. Acetaminophen is very safe within the 3 gram per day recommended doses. So, and there are various strengths. Arthritis strength, acetaminophen is helpful. Tramadol is a non-opiate analgesic that we use a lot. The opiates that, at least speaking for Dr. Churchill and I, the opiates that we kind of limit ourselves to are hydrocodone or codeine. As a rule, we don't do stronger opiates than that. But some of our patients are on them, but typically get them from their family doctor if they need them. So obviously we want you to feel absolutely as good as you can, and it is a team effort. We can do what we can. We want you to, take part and really take ownership of your arthritis. Do what you can also to feel good and take good care of your body. Sometimes I have to encourage my patients to evaluate their expectations. If you're working 60 hours a week, getting 3 hours of sleep at night, you are not going to feel good. No matter what medicine we use for your arthritis, you absolutely need to, evaluate that and see if is that really realistic for you with a chronic inflammatory illness. It's not always quite that dramatic, but often patients are just simply expecting too much of themselves. Managing stress. Stress can trigger arthritis flares, so managing that as well as you can. Getting adequate sleep at night is important. Again, smoking stimulates or just adds fuel to the fire of the inflammatory response. So do what you can to quit smoking. We're happy to help you with that. There are a lot of good resources for that. Staying hydrated is important. It's good for the joints, it's good for the discs in your spine, and it's good for your body overall. Energy level is generally better if you're well hydrated. And with a lot of our medications, it's really important also to be well hydrated. Caffeine and alcohol tend to dehydrate, so non-caffeinated, non-alcoholic beverages for the most part are important. And then it is important to see your primary doctor regularly, every 6 to 12 months. Some folks have to go a little more often than that, but it is important to get the routine health maintenance, health screening visits in. We want them watching your cholesterol and your thyroid and making sure you got your flu shot and pneumonia shot and colonoscopy, all of those things. It's important that your primary doctor is tuned in with that. And mammograms too, don't forget those. There is a modality that has all of these terrific benefits: decreases breast cancer, heart disease, diabetes, Alzheimer's, less male impotence, decreases strokes, makes you feel better, live longer. If you knew what it was, would you do it? The miracle cure is walking. In the literature, it has been shown to have all of these benefits, and this in the studies. These were basically the parameters: 10,000 steps a day for about an hour, 3 to 7 days a week, or about 2 miles a day. Not everybody can do that. Sometimes walking on land is not tolerable for patients, so walk in the water. If you can't walk, there are other forms of exercise certainly that are okay, and you get the same benefits essentially to your body, joints, cardiovascular system. There are some caveats there. If you haven't exercised and you've been sedentary, you're over 65, all of those things, first see your primary doctor. Make sure that you're safe to start an exercise program. Healthy diet. This is pretty basic, but obviously it helps with weight management, which is important for your load-bearing joints. Get plenty of protein. That's important for your muscle mass. If you're trying to lose weight, eating plenty of protein is absolutely essential because that helps you build muscle, which increases your energy burning capabilities, or your basal metabolic rate, and will help you drop the pounds. Red meat, choose lean cuts. There is some talk in the literature about an anti-inflammatory diet, and part of that is staying away from high-fat meats. Generally, lean cuts are just better for you from a cardiovascular standpoint too, but to my knowledge, none of the docs at the Arthritis Center specifically say you know, stick with an anti-inflammatory diet, but we do say basically, you know, eat plenty of protein, enough calories but not too many, lean cuts of meat with plenty of protein, and fish for your omega-3 fatty acids, plenty of fresh fruits and vegetables, that kind of thing too. Stay away from highly processed foods like white flour, white sugar. Another symptom that often folks with RA struggle with is fatigue, which is different than sleepiness. Fatigue is kind of all over. You feel not motivated. You just kind of want to vegetate in a lazy boy. It can affect you physically or mentally, and it is different than being sleepy. Often it can be traced to lifestyle factors, but it can also be related to your RA or to another medical condition. This is just kind of actually an abbreviated list of medical conditions that can cause fatigue. It's a very vague symptom that can be caused by all kinds of things. Many of our patients have many of these different disorders. They can have RA along with diabetes, maybe sleep apnea, maybe depression. So all of those things can certainly add up to being fatigued. So knowing how to manage it is part of your RA treatment. Here's some preventable lifestyle factors that can contribute to fatigue. Alcohol use or abuse. Alcohol, of course, makes you sleepy, but it also interferes with your sleep patterns. It can make your sleep not as restorative. Caffeine or nicotine, particularly caffeine in excess, nicotine at all. If you're trying to do too much, excessive physical activity. Also, if you haven't been doing enough, you get deconditioned and are fatigued from that reason. And obviously, lack of sleep. Often we recommend sleep studies for our patients to kind of rule that out as a source of fatigue. If their RA is well controlled and they're still really, really tired and feel terrible, a sleep study may be indicated. Certain medications can contribute to fatigue. A lot of our folks' blood pressure medications, I think, contribute to that. Then, of course, dehydration and poor eating habits. So optimally, to treat fatigue, we want to identify the underlying cause if we can. If it's a medical condition, we try to treat it as optimally as we can, and then also address the lifestyle factors. And then real quick, a few do's and don'ts about sleep. These are all kind of common sense, but I never cease to be surprised at people who say they can't sleep, but they're big offenders of one or more of these do's or don'ts, I guess. Basically, exercise during the day, not late in the day. Exercise is good because it warms you up, and then your muscles can relax and you're able to sleep. Don't exercise too close to bedtime, though. Keeping a regular schedule is important. If you think about newborn babies, they need that routine so that they can sleep well during the night. We are way beyond that, but still that routine is something that is just built into us, that circadian rhythm, and our bodies do respond to routine. That certain cues mean it's time to go to bed and promote sleepiness. Rituals can help. Also, stimulating activities before bed should be avoided, particularly if you do have trouble with sleep. LED screens like phones and video games or TV really can stimulate the brain and interfere with drowsiness and the ability to get to sleep. Generally, it's wise to not go to bed until you're sleepy, and hopefully if you're following all these other things, you are sleepy when it's time to go to bed. If you do go to bed and you're just tossing and turning, don't stay there. If it's been 20 or 30 minutes, get up, go to a different room, do something that's kind of restful, kind of maybe a little boring, and then go back to bed until when you get sleepy. And then obviously make your bedroom a nice restful place, good mattress, dark enough, cool enough, all of that kind of thing. And then don'ts, kind of the opposite of what I just said. Don't nap too late in the day. Don't exercise too late in the day. Avoid stimulants late in the day or alcohol. Avoid a big meal right before bed. And what's the other one? And nicotine. Also nicotine, up to 6 hours after you smoke a cigarette, it can interfere with your slow wave sleep. So, you know, smokers that have difficulty sleeping, that's really our first recommendation for them. So, that's all I have. Raise your hand. Any questions? Yes?
I have a question about prednisone.
Mm-hmm.
I put on that about